Okay, so we're gonna go over some basics on traumatic brain injury before we get into the condition that we're all researching, which is a functional vision condition or a condition of binocular dysfunction referred to as convergence insufficiency. We have so far pretty high prevalence of convergence insufficiency after concussion, mild traumatic brain injury, which is going to be our topic of inquiry. So let's just get some basics in place for traumatic brain injury. This is a definition of traumatic brain injury from the Veterans Affairs and Department of Defense Clinical Practice Guideline for the management and rehab of post-acute mild traumatic brain injury. So post-acute here means in the subacute and chronic phases. So these are for people that have not recovered from concussions. This manual was first developed in 2009, and then a second version in 2016, and the third version, the 3.0, came out in 2021. So I'm not going to read it verbatim here, but the bottom line: a traumatic brain injury requires an external force, and that external force can be varied. That external force could be blunt trauma. Hitting your head on something or being hit by something would be blunt trauma. It can also be acceleration, deceleration injury without blunt trauma or with blunt trauma. In cases where there's no blunt trauma, you can think of it as kind of a coup contra coup type injury, whereby the classical pattern would be a whiplash injury in a motor vehicle collision. And when that occurs, the brain, which is about the consistency of butter, bounces around inside of the skull. And so it's a very, very hard, bony structure. And you have little bony ridges as well, particularly in the frontal areas, can lead to damage even without blunt trauma. And then we have more recently, blast injury is well recognized as a cause of brain injury. And that's due to pressure waves, which basically go through the head and shear neurons, axons, and so forth. And we finally have penetrating injury, which would be like a knife stab or a gunshot wound. So any of those external forces would fall under the forces required by definition to cause a traumatic brain injury. The rest of it is really, we don't have to go over this, but normally we're looking for a period of loss or decreased level of consciousness, post-traumatic amnesia, which can be either retrograde or antegrade, alteration of mental status, things like confusion, disorientation. Commonly, people will say, I felt stunned or I saw stars, that type of thing. And then any focal neurological deficits, which you see here. And then, of course, in more severe brain injury that's not mild, you can get intracranial lesions, which is referring to the brain proper, or to the meninges, which is the hard outer layer which protects the brain. And you might remember the three layers: the pia, arachnoid, and dura mater are part of the meninges. So an intracranial lesion can occur in any of those areas. So that's the basic definition. That's fairly consistent across different organizations. And so this is going to be common to whether you look at the ACRM guidelines or various neurology guidelines and so forth. And there's a number of them, but it's going to be pretty common in terms of a shared definition. The other aspect of brain injury is to classify the brain injury. And so we talk about this as TBI severity classification. Here again is a classification model or nosology from the Department of Defense. And you'll notice here that there's 5 criteria in the left column. And I'd highlight the top criteria, which is structural imaging. Structural imaging, you might remember, is CT scan in this case on the day of injury. It's fast and it gets the job done, and MRI takes much longer. So we're talking generally about day of injury, neuroimaging, or shortly thereafter, and usually head CT. And here we have normal head CT automatically in the Veterans Affairs model. You're going to start to think it's mild unless you have other factors that are present, like a loss of consciousness greater than 30 minutes or alteration of consciousness greater than 24 hours and so forth. But basically, you're going to score it based on the highest severity level. So if somebody had normal neuroimaging, but they lost consciousness for an hour, you can see that they would then be considered to have a moderate traumatic brain injury. And if they had greater than 24 hours, they would have a severe traumatic brain injury. So in this schemata, you're going to pick whatever is highest, and that's going to then classify the brain injury. But most of what we're talking about with convergence insufficiency and 100% for our study that we're working on is going to be mild traumatic brain injury, what we call the classical concussion. And it'll meet the criteria in the left column. The final one we need to briefly talk about is the Glasgow Coma Scale. And the Glasgow Coma Scale is a emergency medicine triage tool that's used in pre-hospital care by paramedics, EMTs, and it's also used at hospital arrival as well to basically grade the severity of the injury. It should be noted that the Department of Defense no longer recommends using the GCS to classify injury. And that's because it's not necessarily a great predictor of outcome, but it's useful in a triage model where you're trying to get someone to neurosurgery or intensive care unit and so forth. And it's basically, I don't have a schema of the Glasgow Coma Scale, but I encourage you all to look it up so you're familiar with it. It's basically eye movements, verbal response, and motor function. And then based on those criteria, and we can look at that maybe another time in another lecture, you get a GCS score or a Glasgow Coma score, and it'll fall along these lines between 13 to 15 being mild TBI, 9 to 12 being moderate, and less than 9 being severe traumatic brain injury. And generally, the lowest score you're going to get is 3. But you can also have things that are not testable. For example, if they've been hit in the eyes and the eyes are swollen shut, obviously they can't open their eyes when you ask them to, right? Or if there's airway blockage and so forth, or they're intubated, then you can't assess verbal function because they're not going to be able to express themselves, and so on. So there's some limitations, but generally a score between 3 to 8 would be considered severe traumatic brain injury in this schemata. And then, of course, if you have any abnormal neuroimaging whatsoever in the Veterans Affairs Department of Defense model, it's automatically moderate or severe. And that deviates with history, which I'm going to talk about because this is going to be important for reviewers, anyone that's doing epidemiological research in the setting of brain injury needs to understand the distinction between complicated and uncomplicated mild traumatic brain injury. And so we're briefly going to talk about this. So I want to say that this is a historical relic and that hopefully it will remain that way, but it may or may not be. It's still being perpetuated in some literature. But for decades, mild TBIs have been subclassified as either complicated or uncomplicated. And complicated, and the caveat here, and I haven't corrected this, is the thing that makes it a mild TBI in this sort of binary subclassification is a Glasgow Coma Scale of 13 to 15. So historically, many papers and researchers will use this model whereby you have a Glasgow Coma Scale of 13 to 15 and you have a mild TBI. And now it's a matter of, do you have a complicated mild TBI or do you have an uncomplicated mild TBI? And so this slide presumes a GCS score of 13 to 15. And then if you need hospitalization for greater than 24 hours, ICU monitoring, neurosurgical intervention, in the context of my research, acute pituitary hormone changes, although that's not widely accepted except within neuroendocrinology, and any anatomical changes on initial CT or MRI. So what they're saying here is you can have a GCS of 13 to 15, but your brain can be bleeding. And that doesn't quite make sense intuitively, right? We don't think when somebody has a brain bleed, oh my goodness, and that can be in the meninges as well. It can be epidermal subdural hematomas, subarachnoid hemorrhages, or what we call intraparenchymal bleeds, which just means the brain tissue proper, as well as certain types of skull fracture. Those are anatomical changes that are allowed to occur in mild TBI as long as the Glasgow Coma Scale is 13 to 15 historically. And so what it does is it confounds the TBI data in the concussion environment, because we will find that these two very different types of brain injury are lumped together in prevalence data. So one of the first things you want to do when you're reviewing is to look and see which types of mild TBI were included. Was it truly the classic uncomplicated mild TBI, what we now just refer to as concussion, or did it include people that had brain bleeds and other very serious issues that, according to the Department of Defense, as well as Mayo Clinic as early as 2007, would be a moderate to severe TBI. So as reviewers, you're going to want to really pay attention to this. And it's going to confound prevalence data, because you can imagine that to get a brain bleed or a skull fracture, you've got a significantly greater force than somebody that is, playing basketball and they bang their head against their buddy and they end up with a concussion. Kind of a classical, uncomplicated mild TBI. So any questions so far? Yeah, more of the contemporary literature just considers mild TBI to be uncomplicated mild TBI. Yeah, you'll need to, and they may not. They may not even tell you. And so if we need to understand in the inclusion criteria, and this is where you're going to look through the inclusion criteria and exclusion criteria, is how are they defining mild TBI? And many papers will tell you how they're doing that. If they don't tell you, then we have a big question mark, which is, did this cohort include complicated mild TBIs as well as uncomplicated? And maybe that's why the prevalence is like 98%, as opposed to another study that was truly concussion, and now the prevalence is 40%. So that's going to make a difference. And so you just want you to all have this in the back of your mind as you approach literature on traumatic brain injury. Just know this well, and you'll have these slides and you'll be able to refer back to them, and you're welcome to do your own research. I encourage everyone to go to any literature sources or even Google and just start reading what you can about complicated versus uncomplicated mild TBI. And once it's on your radar, you'll start to pick it up a little bit more. So this lecture and what we're doing here today is to give you guys the basic scaffolding and knowledge to become very literate, high-level reviewers in the brain injury space, which will be a unique skill because there's not many people that do that. This is just a quick slide on overview of everything that can go wrong after a brain injury. And here we use the term sequelae in medicine. Lay language would be outcomes or aftermath. And so we're talking about types of disorders, conditions, symptoms, signs that can occur following brain injury and persist into the subacute and chronic phases. And chronic phase generally, although it depends on definitions, but generally 3 months or later is considered to be chronic phase. And then you'll find a lot of literature deals with chronic conditions at 12 months or greater. And that's always of interest to us because it represents a plateau. Whereas, if you're looking at stuff at 4 months and you're calling it chronic, it's not really what we would call late chronic. So sometimes you'll see the term late chronic to mean 12 months or greater. And once you're at 12 months or greater, the prognosis is different. So much greater struggle to recover, and things that are stable and have crystallized are more difficult to treat or reverse or rehabilitate. But this is just an overview to see what are all the things that can go wrong. And our group is focused here on vision and ocular motor disorders. And we're focused on just one of those. So you can imagine what a world of research brain injury is. If you were to go into every facet of every one of these areas, we'd have like 300 PhDs working for us at some point, which would be great. But it's a lot to cover in brain injury medicine. Convergence insufficiency. So we're going to do some background foundations and key concepts for convergence insufficiency. So the first thing is to say, where does this fall under visual function? So if we take a 30,000-foot view of visual function, you can sort of divide it, and there's different schematas, but this one divides it into 6 categories: visual acuity, color vision, contrast sensitivity, dark adaptation or night vision, visual fields, and binocular vision. And visual acuity is what we're most familiar with. Many of us wear glasses or contacts, and that's what's going on most of the time when we go to the optometrist and we have a vision change. It's visual acuity, unless you've had a brain injury or something and you're using prisms, and you might have heard of prisms, but those are used in context of convergence insufficiency to treat the condition. But normally visual acuity, Snellen charts, which we all learned when we were doing neurological exam, you could do a Snellen at 14 inches, you can do a Snellen at 20 feet. 20/20 comes from the 20-foot version of the Snellen chart. That's visual acuity. We're not doing that. The other one that we all learn in neuro exam is visual fields. So everybody remembers the nasal fields or the temporal fields and are intact and so forth. So we're not doing visual fields, although visual field deficits can occur, and usually that happens after more severe type brain injury. So we're focused on binocular vision, and binocular vision just means what it says. Bi meaning two, and ocular meaning the eyes. So two eyes. So how do the two eyes work together in concert as a team to efficiently achieve visual tasks, like having two engines on an airplane or on a jet, and if one of them fails, what happens, right? So you've got to have two engines that are working efficiently and are basically at the same power and so forth to keep the plane straight. And when you lose one of those, or the power reduces, then the plane does not stay stable. If there's any pilots here that want to correct me on that, you're welcome to. Just let me know. Okay, so other related terms for binocular vision are going to be ocular motor function, oculo meaning eyes, motor meaning movement, eye movements, and then commonly eye teaming is just a way of thinking about it, and that brings in the idea of the eyes working as a team collectively. So within eye movements or ocular motor function, you can see that there's five different types of movements here. The first two are reflexes. And so the vestibular ocular reflex involves the vestibular system or the inner ear, and basically to keep the eye movements stable as we move the head. So either up or down. So, a basic test of vestibular ocular function would be to pick a target and then simply turn your eyes, and as they maintain on that target, that's a normal reflex. And that can be done by the examiner, and it can also be done in video head impulse testing, which is a computerized way of doing that, which can pick up more subtle deficits. And then the optokinetic reflex, basically, when you're driving and you see telephone poles going by and your eyes hit them and then they jump back to your front target, that's a normal optokinetic reflex. And there's different ways to test that with like an optokinetic drum. I use an optokinetic flag. The very best way is, again, computerized equipment that's used within the field of neurootology. And most regular mainstream medical neurologists don't use that type of equipment. They'll use an optokinetic drum, which is less sensitive. So then we'll come to Convergence in a minute, which is what we're doing. Smooth pursuits, just like they sound. So if you take your finger, we did that last time, and you just track it, that's a smooth pursuit. And you can do that in different directions. You can make little boxes. So if you were watching a bird fly across the sky slowly, or an airplane, that would be a smooth pursuit. Saccades are jumping eye movements directed towards target. So if you're testing saccades, a simple way is right, left, right, left, right, left. You can do diagonal, up, down, but it's the ability of the eyes to quickly jump from target to target. And there's a whole study of saccades. There's literally books on saccades that you can read and on the neurophysiology. And there's different types of saccadic eye movements, which are not our topic. And then finally, the topic that we're interested in is vergence. And this is basically the eyes moving together functionally to lock onto different targets at different distances. And convergence is when the eyes come in, turn in, and divergence is when they go out. So if we bring our fingers in towards our eyes, which I recommend everybody does, we did that last time. Just Ryan, you have to participate too. And bring it in, that's convergence. And then as it goes out, you're diverging. So you can have a convergence insufficiency or excess, which means they overconverge. You can have a divergence insufficiency or excess. So within those vergence abnormalities, we're interested in convergence insufficiency, which is as the target comes in, the eyes are not able to lock in on that a target to maintain one, and you get diplopia or double vision. And it affects reading in particular, so near work. So you can see here, this is a little schematic of the eyes working in convergence and divergence. The vergence neural pathways are extremely complex. You might remember that we have 3 cranial nerves that are associated with eye movements. And I quizzed you guys last time, and I think you got some of them. I don't know. But they're basically cranial nerve 3, 4, and 6. So ocular motor nerve trochlear and abducens, and they innervate 6 different eye muscles. And we don't have to go over that unless we want to do an anatomy class sometime, which I love. I love anatomy and all that stuff. But if you guys ever want to do that, let me know. I'm happy to teach. But basically, it's not just cranial nerve deficits, and you can get a cranial nerve palsy where the cranial nerve is actually damaged and it leads to convergence insufficiency. But most of the time in mild TBI, that's not what's going on. And we don't actually know what's going on. So a lot of the researchers say, yeah, the neural pathways or substrates are so complex, we don't really know. So this is not for you to memorize at all. This is just to say, here's a systematic review on neural pathways, and you can read that, and it's a lot to take in. It's a lot of neuroscience. It's complex, and the consensus amongst most researchers is we're not quite sure. But we know what the functional deficit is. We just don't know exactly, is it focal in the brain? Is it multiple sites? It's hard to say. Binocular vision disorders, those are some examples. You can see, we talked about divergence excess. So basically, that just gives you a little bit of an overview. There's more disorders of binocular vision. Those are just some common ones that are mentioned there. So what does this do to a human being that we're seeing as a patient who comes to us and says, I had a concussion and I don't see as well as I used to? And you say, well, what do you mean you don't see as well? And they say, well, when I read in particular is usually the complaint. So the characteristic one is double vision with near work, and it often resolves with blinking. So they'll blink or they'll really focus and they can kind of get the eyes to work together, and then they break, and so forth. So you'll get intermittent double vision, intermittent diplopia. Same with the blurred vision. It's oftentimes intermittent. Words can jump, move, swim, float on the page, losing place when you're reading, slow reading, reduced reading comprehension, poor concentration, and then eyes get really tired or uncomfortable, and people just get really exhausted. They'll tell you, yeah, I used to be able to read for 3 hours, and now I read for 5 minutes and I want to take a nap. That's kind of a red flag. But you got to ask them about reading. And reading clinically, for me, has been the highest yield question to elicit this, because people don't oftentimes, if you do an ROS, like I do at my clinical review of systems, and you ask about vision on an ROS questionnaire, people will often say, no, I don't have a problem. And then you ask them, you answered no, but and so I never believe them. When they put no, I don't have visual problems. And then I'll ask them again in clinic, and I'll say, any vision changes? And they'll say, no, not really. And I say, well, what about reading? Well, what do you mean? How long did you read before? Oh, I was an avid reader. Do you read now? No, I don't read anymore. Why? And then you ask them, and they're like, well, actually, when I try to read, I get headaches, or when I try to read, my eyes hurt, or I can't remember what I read, and it's really frustrating, so there's no point. So you get into that, and then you do your physical exam, and you can often uncover it on a bedside physical exam, which you're going to read about in the studies. And then you confirm that with a special optometrist called a neuro-optometrist. But these are some of the symptoms that are very, very common with convergence insufficiency. The other one oftentimes is using a ruler or their finger to trace words where they never had to before. So these are some of the symptoms of convergence insufficiency. So let's keep going. We're going to go into definitions, diagnostic criteria, and measurements to determine whether someone has convergence insufficiency. And right here, I'm just highlighting that it varies between studies, at least the studies that I have in my library, and it varies between specialties. And so you've got two main specialties that are involved in diagnosing convergence insufficiency. You've got optometry and you've got ophthalmology. So ophthalmology is a medical doctor that goes down a neurology tract, and they usually become eye surgeons. And they're often focused on structural problems with the eye. And that's different than optometry, which is not a medical doctor or somebody that does 4 years of training just in vision. And so your optometrist is going to be the one that you go to for glasses and prescription changes. Within optometry, there's a subspecialty of basically neurooptometry, and there's additional training. The fellows of the College of Optometric Vision Development, and they deal with functional vision disorders that are either congenital, developmental, or acquired, such as in brain injury. And that could be acquired, that could be stroke, it could be traumatic brain injury, and so forth, and other neurological conditions. So MS, Parkinson's disease, et cetera, neurodegenerative diseases. So that's optometry. Optometrists are the ones that generally prescribe and supervise vision therapy or vision rehabilitation. Ophthalmologists do not do that. So there's differences between viewpoints from these two fields. And my experience has been that often ophthalmologists sort of downplay the significance of convergence insufficiency, whereas optometrists tend to appreciate it and treat it more often. You could argue that that's a bias because they have financial interests. So that's one criticism from ophthalmology as well. You're more interested in treating the condition because you make money on it. And that's always something we have to consider. My experience, when I refer, I do not make money. So I refer because somebody's suffering and I want to get them better. My experience working with concussions is it's a very real condition. It's treatable. People get better. They feel better when you treat it. Sometimes you can give them simple stuff to do at home and that resolves it. And sometimes it needs more in-clinic vision rehab. So convergence insufficiency, we're gonna go over definitions. It's going to get pretty thick now. And so we're going to be going into looking at the different diagnostic criteria. So the terms I want to kind of bring out to start with are near point of convergence. And you'll see it says here a receded near point of convergence. And the near point of convergence is basically defined in two different ways. And you want to be aware of this. This is critical information as a reviewer. So the near point of convergence is defined as either an objective break in convergence viewed by the observer, aka the doctor, or a subjective break, which is defined subjectively by the patient reporting double vision. So let me give you an example. One would be you bring a pencil in or another instrument. Pencil's not ideal, and the eyes are moving, and then one of the eyes breaks like this. So you'll see the eye kind of turn out and it'll break. That would be an objective break in the near point of convergence. And then that would be called the near point of convergence. And we would say, is that normal or abnormal compared to normal controls? Subjective would be, we don't see it break necessarily, but the person says, okay, it's double now. So that's the subjective break. Different studies define this in different ways. The convergence insufficiency treatment trial, which is arguably the most robust study to date, says it's the subjective break or the objective break, whichever comes first. And it's usually subjective is usually reported before you observe an objective break. So that's near point of convergence. So if everybody comes in, and we tested that in everybody last time, and everybody had really healthy near point of convergence, that's by far the most important metric that's used. And you'll see some studies that use only near point of convergence. They don't even mention the other criteria. But to look at convergence insufficiency in a classical way, in a more robust way, there are other criteria as well. And so exophoria at near greater than distance. And exophoria, we'll look at a video when we have time of what an exophoria looks like, but you have to bring it out on a certain type of testing called cross-cover, cover testing. But the basic idea is that one or both eyes are deviated outwards, exo. And then and that outward deviation is greater at near than at far. And there's different metrics for that. A classical one is a 4 diopter difference to meet the criteria. We'll go into diopters later, but for now, just plug it in your head that exophoria at near. I want to break this into chunks and then we can do scaffold learning. So exophoria at near greater than distance. And then how much greater at near than distance? Question mark. That's what you're going to be looking for. If the paper's using exophoria at near or greater than distance as one of the criteria, there's going to be a cut point. And so we would say a minimum, for example, a minimum of 4 diopters. And again, we'll come back to diopters. Diopter difference or greater is one definition. There's not consensus on that. You'll see it depends, but that's a common definition. So exophoria at near greater than distance, and then reduced positive fusional vergence or convergence amplitude. So I'm going to show you, I'm not going to try to explain this without some visual aids. So let's just get the terminology down right now, positive fusional vergence, or it's also referred to as convergence amplitude. And we'll talk about that when we look at the instruments that are used to measure it. And then the other one is ACA ratio, which is accommodation convergence to accommodation ratio. And this is used, but it's more often in pediatric studies. And we're probably not going to see a lot of it in adult studies. And the reason is accommodation, you lose accommodative faculty with age. So accommodation is the ability for the lens, which is very pliable, to change shape with targets at different distances. And as you age, the lens hardens, and in your 40s and 50s, you develop something called presbyopia. And 100% of people get presbyopia, at least right now. There's some science that's changing that, a pharmaceutical, which may actually reverse it, which is cool. But right now, everybody gets presbyopia. So if you've got a cohort and they're using ACA ratio, they have to adjust for presbyopia. So let's remember that. So there's some new terms here. So I'm big into like repeating things, right? Repetition is the mother of learning. We all know that. And so the new terms we've learned are near point of convergence, exophoria, positive fusional convergence, and here ACA ratio. And we also learned the term presbyopia, which is age-related changes in vision that are due to the lens hardening. You can have some corneal influence as well, but it's predominantly lens or lenticular. To do that, I want to quickly look at the sort of gold standard study to date. This is the Convergence Insufficiency Treatment Trial. This is a pediatric and adolescent study, but many of the principles apply to adults. What won't necessarily apply is the normative data, right? So there's some heuristics that are used, and I don't encourage heuristics because we're much better off looking at controlled studies with normative data than heuristics. But a common heuristic that's used is anything greater than 6 centimeters for kids and adolescents and very young adults, and anything greater than 10 centimeters near point of convergence where it breaks, you get that double vision or that observable break, is abnormal. That's not a very rigorous way to do this. We need to understand what's the instrument, how was it vetted, are there controls for that particular instrument? And we're going to talk about those instruments in a minute for near point of convergence assessment or measurement. So this is from the Convergence Insufficiency Treatment Trial. The take home from this particular slide is while the study focuses on individuals with all 3 aforementioned signs, the authors acknowledge other variants of convergence insufficiency, which include at a minimum 1 of the aforementioned signs. So the classical convergence insufficiency would be A plus B plus C of the criteria, plus symptoms. You really got to have, well, you got to be symptomatic. I mean, you want to have some symptoms. But of the objective criteria, the signs, 3 of 3 would be classical. But what they're acknowledging here is that somebody can have just 1 of 3 and still have functional impairment, meaning they're not reading well, they're getting headaches, they've got all the symptoms, and they still need to be treated. So there's a debate over this. I've seen ophthalmologists argue, oh, you have to have all 3 or it's not really convergence insufficiency. And then I've seen optometrists like Dr. Cadet that I work with closely say, no, that's not the case at all. If they have 1 of 3 and they're symptomatic, they're going to benefit from treatment and they need treatment. So there's that debate over all or 1 sort of. So we want to be paying attention to this as reviewers. Are we just talking about NPC, near point of convergence? Are we talking about all 3? So we want to understand what's the diagnostic criteria in the study. And then you'll see here, look at the 6 centimeters. And that's because this is a pediatric adolescent study. So they're using a cut point of 6 centimeters to define abnormality. And then here's where the 4 prism diopters comes from. So exophoria near at least 4 prism diopters. We'll look at diopters later. It's impossible to look at it without giving you a visual. So we'll go online and we'll look at some graphs around what diopters, how they work. But so there's the convergence insufficiency treatment trial cut point of 4 prism diopters, and then insufficient positive fusional vergence. And I'm not going to get into Sheard's criterion today, but basically less than or equal to 15 prism diopters base out. What base out refers to is prisms. And so wish I had my prisms with me today. I don't. They're at a different clinic. But prisms, basically, you can turn them in 2 directions, and they're a little sliver. And so there's base in and base out. And so depending on the direction that you turn. And so you're challenging the eyes, basically. You're changing the angle of light refraction, and then you're challenging the eyes to work with that to maintain vergence. Maybe what we can do is find an online video where they're testing positive fusional vergence. It's easier than trying to describe it. Okay, I know that's a lot so far. How are we doing so far? Okay. Okay, cool. Yeah. Okay, so everybody feels good. Slow me down or stop me if we need to repeat something. So that's just an extraction from the last slide. That's the CITT Convergence Insufficiency Treatment Trial criteria, which again, pediatric adolescent population. But that's not going to be the same for adults. What'll be the same is the near point of convergence, maybe the use of exophoria, maybe the use of positive fusional vergence, but the cut points will likely be different and maybe method dependent. And that's what we're going to talk about. So one of the things as reviewers that we want to look for is, instruments that were used to measure near point of convergence, exophoria, or PFV, positive fusional vergence, and then the normative data that supports that instrument, if they used it at all. Or did they use like a consensus, or a heuristic, like 6, for example? Those are good important questions as we're reviewing. This is to give you a sense of different fields and how they look at this. And so this is the optometric clinical practice guideline. But basically, as we look at this document, you'll see here that they define classic convergence insufficiency consisting of receded near point of convergence, exophoria at near, reduced positive fusional convergence, and deficiencies in negative relative accommodation, which is ACA ratio, essentially. And again, they're reiterating not all patients have all of these clinical findings. So we're not necessarily looking to have all those criteria. And then what they're saying here is, let me just look here. Common convergence insufficiency highlights the importance of near point of convergence. So again, we're just reiterating what we've just talked about right there. Neuro-ophthalmology, remember ophthalmology are medical doctors in the track of neurology that do surgery. They have their own manual. So this is their take on assessment of convergence if you want to read it. So there's a couple points that I want to bring home from this reading. Convergence is tested with an accommodative target that has enough detail to require an effort to see it clearly. A pen light or a finger is not adequate. And so notice that, because many of the studies will use a pen light or a finger. And what they're saying here, an accommodative target requires that you have to activate the lens. And so when you read a letter, for example, so a common accommodative target would be, I don't have my pencil with accommodative targets on it. I had it at my last lecture. It'll be a pencil that has little letters on it, like A, Q, Z, P. And then you ask them to focus on Z as they come in. That would be an example of an accommodative target. And so they have to activate more of the visual system. So here the field of ophthalmology is saying it's really not, using a pen light or a finger is inadequate. And yet in my work, many times I see reports coming in from ophthalmologists and they used a pen light or a finger, literally. So that they're not even following their own guidelines. And that's what I mean. A lot of this is not taken seriously. It's like, well, we got eye surgeries to do. Let's just follow. They learned something in their residency and they keep doing it the same way. So that's what we're talking about here. So this is straight out of ophthalmology. So, and then you're noticing here, they're saying a normal NPC is 3 to 5 centimeters from the nose. I don't know where that comes from. There's no citation. That's very short for an adult. And so they don't differentiate between children or adults here. So again, this is probably consensus heuristics. I don't know where it comes from, but it's not well cited. And then the fusional convergence, which is the same as positive fusional convergence, they'll give you a couple different amplitudes. So they're using 25 prism diopters for distance. And so you can measure positive fusional vergence at distance or at near. And the near measurement is more important for defining convergence insufficiency. So as you're paying attention, if they are doing positive fusional vergence measurements, make sure you're looking, did they do it at distance? Did they do it at near? Did they do it at both? And then what were the prism diopters that were used to define abnormality? Okay, so then accommodative convergence is a bit more sophisticated. This is something that I'm not going to get into you without my neurooptometry colleague coming on, because it's above my pay grade, honestly, and it's not something that I do in my clinic. But you can see basically it's done with instruments that I don't have. So I can't do this in my clinic. So I've observed, I've done a lot of clinical rounds with optometry observing, but it's not something that I do every day. So this would be something for us to talk about with a neurooptometrist. If you're really, really interested, could have them come on one day. But for our purposes, we're just looking to see if they used ACA ratio, which again is accommodative convergence accommodation ratio. If they use that to define convergence insufficiency, yes or no. And if so, you've got, a normal ACA ratio here is 3 to 5. The bottom line is, let's flag papers that are using accommodative convergence accommodation ratio and just kind of highlight that. And then we can come back and explore that a little bit more. One of the things that I do want to highlight that's often not done clinically, and I read a lot of these chart notes from optometrists and ophthalmologists, is asking the patient to report their reaction to the testing. So how they feel when you stress their eyes. I've had people break down crying in front of me. It's that difficult for them. Or their eyes start to water, or they get a really big headache, or they tell me I'm feeling dizzy. So I always when I'm doing my testing, I'm always asking them every minute or so, how are you feeling? Any symptoms? How are you feeling? Any symptoms? That's often not done. Hopefully in some of the studies it will have been done, but it's something to pay attention to. So there's the baseline symptoms we want to know about, the symptoms of convergence insufficiency, which we reviewed, but there's also symptoms in response to challenging the visual system through the testing itself. That's also important. And that is very much underreported in chart notes and likely in the studies. So just something to call your attention to as reviewers to be aware of, to see if they actually report that. So that would be testing elicited signs and symptoms. A sign would be their eyes water or they get nystagmus. Symptom would be they tell you they've got a headache, they feel dizzy, they feel nauseous, those types of things. Okay. So the other thing to be aware of is the convergence recovery point. So the convergence recovery point is, let's say that it's coming in and I say, okay, doc, it doubles. And then I back out and I say, tell me when it becomes one, single. So then that's the recovery point. Or it can be objectively defined when the eyes lock back in after they've broken. So we want to look to see if they're reporting convergence recovery point as well. So near point of convergence recovery point. Not going to cover this. This was just something I was going to, when I had time, go over with you guys, but not a problem. We don't need that today. So really, this is the summary of considerations. We've got really 5 things we're thinking about. We're thinking about the symptoms. And I'm going to briefly show you the Convergence Insufficiency Symptom Survey, which is a checklist of symptoms. It's a self-report measure that's used. And it would be good to know, sometimes it's used, sometimes it's not. Near point of convergence, exophoria at near or greater than distance, positive fusional vergence, and then our ACA ratio. So that's really what you need to know. And then we've got to parse things out within that. That's a copy of the CISS right there for your reference. And then we should probably break this up into a different lecture, Josh, where we really get into the details of this, because we're not going to get through all this material today. But you'll notice here that there's going to be a checklist for all of you where we're going to go through how was it measured, for example. Was it a finger? Was it a pen light? Was it a transilluminator? Was it an instrument like the Royal Air Force rule or the Astron International rule? And I had a picture that shows you those different instruments. So that gives you an example of different ways that you could measure convergence. And most of those aren't using an accommodative target, are they? Nothing in the top row is using an accommodative target. The only one that's using an accommodative target there is the one in the middle, which is the Astron International rule. That's the one, the bottom middle is what's used in the convergence insufficiency treatment trial. But that shows you that there's many different ways. And so we need to understand, how was it measured? How was the normative data generated? Was an accommodative target used? There's also gaze position. You might not be thinking about this, but you can elicit different responses depending on the gaze position. So natural gaze would be straight ahead. So you can imagine coming in towards the middle of the brow line. Downward gaze would be slightly over the nose, and then you're coming into a point at the nose. So if they mention gaze position, we need to make a note of that. Again, reviewing the definition of the break point. Was it objective, observed, or was it subjective report of double vision? The other one that's really, really important, and I can't stress this more, is how many times did they measure it? Was it a single measurement? Was it measured twice? Was it measured 3 times? Was it measured 10 times? So the standard we use at our clinic with the Royal Air Force rule is 10 times. And the reason is people fatigue, and that's part of the illness. That's part of the condition, is that the eyes get tired very, very fast. So if you get a delta or a change, right? Imagine the first near point of convergence is 11 centimeters and it's 30 at number 10 on the measurement. Do you think they've got a problem? They should be able to maintain that same convergence ability across 10 trials if the eyes are healthy. So we want to look at the number of measurements as well. We want to look at the diagnostic cut point that was utilized. How was it determined? Was it consensus? Was it normative data? And then if they're using an accommodative target, then we have to consider presbyopia. So age-related loss of visual acuity due to primarily the lens hardening, get some changes in the cornea too. But yeah, are they adjusting for presbyopia? Are they considering that if they're using an accommodative target? And then are there any testing elicited symptoms that are reported? So that's pretty much your checklist for near point of convergence. And that's an example of normative data. I just want to briefly cover that. These are examples, Royal Air Force rule, pin target. This is an example of normative data that was done for different age groups. So it shows you that it's there in the studies. Not everybody reports it. This is exophoria at near. We'll have to cover this another time, but there are different methods for measuring exophoria. So Thorington, modified Thorington, Von Graaff, Maddox rod, and then the same types of questions that need to be asked about measurement. So again, method of measurement, cut point criteria, distance versus near, those types of questions. I had a video there that's not linking up, unfortunately, but I've got a link there. I would encourage you guys will get these slides. Just click on that video and he will show you an exophoria at near, and you'll be able to see what it actually looks like when we're using that test. And then positive fusional vergence can be measured in 3 different ways. So prism bar, rotary Risley prisms, and 4-opters. And what those look like is right here. So that's a prism bar on the left. That's a rotary prism, which is it's smooth instead of stepped. And then the 4-opter is the fancy multi-$1,000 equipment that you get in an optometry clinic, and they're adjusting the prisms this way. So the normative data is going to be different depending on the method used. So if positive fusional vergence is used to define convergence insufficiency, what did they use? Prism bar? Did they use Risley? Did they use a 4-opter? So that's the take home there. And again, the same issues with diagnostic cut points, adjustment for presbyopia, all of those are going to be the same. Subjective versus objective report of either break or double vision, all the same there. And then the ACA ratio, there's 2 methods. There's a lens gradient method and there's a heterophoria method. I doubt we're going to come across a lot of this. It's not in a lot of the adult studies, but if you do, just be aware. Method, diagnostic cut point. How was the diagnostic cut point determined? Was it adjusted for presbyopia? Consensus versus normative data, those types of things. Those are going to be consistent across the 4 different measurements that we've covered for near point of convergence, exophoria, at near, positive fusional divergence, and ACA ratio. So you kind of get the pattern now of what we're trying to do with this. And then this will be there this is a master checklist at the end that you can just go through. And that's pretty much it. Ending with the diagnostic threshold question, just in review. Was it 1, 2, 3 criteria and so forth? How many need to be met to be included as considered having convergence insufficiency? So